A very good evening to all of you, and welcome to this event, a very exclusive event that we are doing. So, we are a bunch of girls who are on screen, and there are special guests who will be joining us very soon. Okay, so I just wanted to say about this event that we are conducting. As being in the oral healthcare domain, we all know that April is the month where we celebrate, or rather remember, about oral cancer. So I myself being an enthusiast, and my specialty is oral cancer genetics. So today we thought that to commemorate this particular month, we gathered together today to conduct this very fascinating event with all young minds and very energetic and hot blood. Okay, so I'll just brief shortly, and you see Gitika with us, Dr. Mary with us, Shreya with us, and we'll also have our guest speaker very soon. And I'll take you through a small, short journey where I today don't want to share stuff, but I just want to share some thoughts that runs in my mind, and I seldom think about those things. So just see that whether we really need to think on those thoughts or those questions. Okay, so I'll just brief. So after my session, we will have our special guest session. And when Sir comes in, that time we will introduce him. And today we will learn about how you can handle, stuff like mucositis or any precancerous lesions as such when it comes to inside your clinic with non-invasive laser therapy. Okay, and then we have a very very interesting thing that is going to happen, and you have to for that you have to still stay with us till the end. So all these people you see, so Shreya, Mayuri and Gitika actually will be conducting a fantastic activity. It's a hands on activity where they will show you or tell you the basic concepts of biopsy, because we cannot go away or just forget about the gold standard. So the attempt through this activity is just to clear our basics more, and then see that with the non-invasive holistic approaches and the gold standard, what we can do for the future with oral cancer. Well, then I will just share my screen and give me a moment. And if you are here, then please share in the comments that you are here. Give us some highs and hellos so that we feel energetic and we really think that we are not robots and we are talking with real people. And don't forget to subscribe this channel, because it's just a beginning and we'll come up with great stuff in the future, near future, and almost every week I come up. All right. Okay, then. So, okay, Gitika, Shreya, and Dr. Mary. So, can I start my session? All right. So, I have got the permission from my gang. So, I'll not waste time. And today, basically, as I said, that I'll tell you a story. And I really don't want to give you information. Is my screen visible? Can you just unmute and tell me, any one of you?
Yes, ma'am. It's visible.
Okay, great. Today, I want to tell you the story of Dr. Manu Dua, a dentist who succumbed to oral cancer. Well, it might sound that the beginning is a bit negative, but it's not negative. This story, this fact, has actually driven me a lot, and I think, like me, many other people in different parts of the world are thinking in the aspect of oral cancer and its dreadfulness, and where exactly we are going and what we can do with the existing advanced technologies as well as the gold standard. As I said in the beginning, I don't want to share any information, because I think we connect to stories, and we these are real life stories which helps us to understand what exactly can be done. So, Dr. Manu Dua was a practicing dentist in Calgary, Alberta. He was only 34. He was a young, lively, well built, and energetic guy, and he was ready to take up any challenges that comes his way and grab every opportunity that comes in his life. And if I tell you a bit in pointers about his lifestyle, because seldom we relate oral cancer with deleterious habits. Manu was a kind of athletic, he was muscular, he ate healthy diet, he exercised regularly, he did not smoke at all, and he was only an occasional drinker. At a point on his 33rd birthday, Dr. Manu's life got interrupted. He discovered a lesion on his tongue. Well, being a dentist himself, he went and just consulted. He just did his own, diagnosis. He just consulted with his oral surgeon friends, and he never believed that this was something to be worried about. Well, in almost less than 2 years, he was diagnosed with squamous cell carcinoma of the tongue, stage 2. And as the standard treatment protocol, he had to undergo surgery and with the hope to get rid of this dreadful, monstrous disease. Well, very good news, the surgery was successful. And he came back, he recovered, and he went back to his normal life. Manu was very happy. Unfortunately, a year later of the surgery, he again noticed a swelling on the left side of his neck. So, this now was a lymph node that was missed in the last surgery. And the cancer, the monster, was back in his body. And this time it took over silently through his entire body, and it started affecting his whole system. It was the time when it was Manu's 34th birthday, and the time was around the beginning of this pandemic. Around his 34th birthday, Manu had to return to the hospital for more cancer treatment. He battled around 33 chemotherapy rounds along with radiation treatment, and his health slowly deteriorated to the extent that he could barely breathe, eat, talk, or sleep. And at the age of 34, he walked away on the path of afterlife journey. Very unfortunate event indeed, isn't it? Just to mention, go in Amazon, and if you want to grab his book, which is called as Life Interrupted: Dr. Dua Survival Guide, which Dr. Dua penned down his learning from the battle of living and surviving during his last days on this earth. And this energetic guy never believed that it could be cancer, because when he saw the lesion, even his oral surgeon treated him for lichen planus. He said, "It can't be cancer, I'm too young." Well, that's the dreadfulness of a cancer. It can knock at any time. So the question is, could early detection of the cancer save Dr. Manu Dua's life? Think on it. And if you have at present any answers to this, please feel free. And if you're watching this, you are with us in the live, or you will be watching this as a recording, feel free to write your thoughts, your comments, if you have anything that you know. It will be helpful for the greater mass. With this question living with you, I will move ahead to give a little brief, basically, what we all know. So, oral cancer is the sixth common cancer, and why we talk about dental genetics or oral cancer genetics is, let's see how important this becomes. So, any cancer is the absolute transformation from normal to abnormal, as you can see in this small clip. It's basically the oral squamous cell carcinomas. These are live cell imaging, which is growing in a petri dish. So, any transformation from normal to abnormal involves a lot of genetic changes at different levels, which we generally call as mutations. And that oral cancer is very common. We don't have to justify it. It's all everywhere in the scientific publications, and there are lots of reports from long. And yes, deleterious habits like alcohol and tobacco use actually bring changes to certain genes due to which these mutations happen. Some of the very notable genes would be APC, P53, that is tumor suppressor genes, proto-oncogenes, and genes exactly which are controlling normal cellular process, because we all know what cancer is. This is just abnormal cellular growth. So just in one slide, we can understand the basics of the oral cancer, the genetics behind it, how exactly these genes are involved, how do they work? Well, mostly the genes encode signaling molecules and like or other growth factors which are involved in cellular growth, and under different external stimulus they get activated or deactivated, and thus it takes one normal cell towards abnormality. Okay, very good. So, how does this kind of an information help a dental professional, whether you are a clinician, practicing person, or a student, aspiring dentist, or a aspiring professional? This kind of information, first of all, helps us to segregate the risk group people. A very common example, I don't want to extend this more because these are all known facts, just it's a kind of reminiscence that we are doing today. See, if we can pull out people who have more risk to get this dreadful disease out of an entire population in a specific region, then we can actually go into more personalized therapy. Understanding the genetic basis helps us to understand the pathophysiology of the disease better. This leads to the correct diagnosis. If, as clinicians, we diagnose correctly, obviously there are a lot of treatments and we will definitely go in the right direction, and we will help the patient to get a successful life. Well, this knowledge will empower you to do all these things and more. But these are the three most important areas, that is, understanding the disease pathophysiology, correcting it, diagnosing it correctly, and proper treatment. That is how we can change the life of a person. In this regard, I will definitely like to mention about the program that we are doing, that is Fellowship in Dental Genetics and Clinical Diagnostics, which is a 6 months, 100% online course. This course will help you to understand not only about oral cancer, but about different oral diseases and basically the gaps. That is, the gap with technologies, knowledge about technologies that can be used, the knowledge about already available services that can be used, and as a clinician or a clinical researcher, establishing yourself right from the scratch, from an idea to bringing up a project, or just analyzing your clinical data and making a conclusion. And in a country in like India, where the population is so diverse, we have a diverse genetic. I mean, it's a law. It's a very to say that we have a very potent genetic diversity. The east doesn't match with west. The north doesn't match with south. So it's something like that. There's a lot of scope to work on. The question is early detection possible? What do you think? Is it possible or not? Let me see, I can give you some information which is available. What weapons do you have? We have in hand. Do we have some solution at hand or we have nothing? Well, we have a lot of knowledge at this moment when it comes to understanding our DNA. So picking from there, I have just put two things. We have something called, that is, power of genomics. Genomics is nothing but using different technologies, we analyze our DNA. This kind of technology helps to predict the susceptibility to getting the cancer. That means even before the person is getting, you analyze the risk. Second can be personalized cancer therapy. So this is the way to go, and the world has already started moving. And it's not about that it is not available in developing countries like ours. It is very much available. So this personalized cancer therapies or these kind of processes helps to predict which patients are more likely to respond to specific cancer therapies. So, my dear friends, what I want to say is that with this kind of knowledge weapons, you can do two things. You can actually understand even before the disease has happened, and brings us to that old proverb, prevention is better than cure. And second, you have, if you are dealing with a patient, is the personalized cancer therapy or stuff like this helps to understand which way to go. Like whether when we do chemotherapy, it's still a trial and error. It work, it might does, it might not work. But all the pain is taken by the person who is suffering from the cancer. So, as clinicians, as scientists, can we not do something from our end to make their life a bit easier? I'm not telling by doing this we can ameliorate cancer. Hopefully, one day we can. But at this moment, we can change the life of a person, we can ease their pain in a much better way. So, how can you use technologies towards patient care? So, as I said, I will give you two examples. You can go for predictive genetic testing using stem cells. There are a lot of companies who does this. It's a genomic boom already in our country as well as in abroad. It has been existing from the more than 2 to 3 decades, I guess. And there is something like genomic testing, predictive genomic testing using saliva. So as you see, as a clinician, as an oral healthcare professional, what can you do? You can make yourself informed with this information, and exactly what you have to do if you're working in a clinic, or if you run your own clinic, or if you're a student and you're working in an institution, whoever you are from the fraternity, what you can do, you just have to know how to collect the sample and send it to the right people. So basically, you, whichever thing you're choosing, you collect the sample, send it to the laboratory, and they will specify you everything. They will do the hard job. They will give you test reports with analysis and interpretation, from which, as a clinician, these reports will help you to take informed decision. And again, the fraternity of genetic counselors come in, who again helps in this a lot. Not in every case, but yes, their role is very big here. It is simple. In this way, if you are a practicing person or a professional, you can add on little revenue as well. And apart from that, just think how good you are doing to your patient. You are actually directing him towards a more healthy life. That is what you are doing. And that's a moral duty when we get this degree, doctor, in front of our name. So, some thoughts which I want to today just share with all of you. What lessons should we learn from Dr. Dua's life story as oral healthcare professionals and scientists in the oral cancer space? Is it only about encouraging more oral cancer screenings, more referrals of suspicion lesions for biopsies, more patient education about decreasing deleterious habit that add to risk factors? That is, doing more and more what is being very diligently done from years together by the entire fraternity of oral healthcare professionals in their best capabilities and at the entry level? Or can we change a bit? And is it not time that we, as informed oral healthcare professionals and scientists, start looking into things a bit differently? Can we not add a newer perspective to the existing efforts? Can we learn and educate to look into genetic perspectives of the deadly oral cancer disease? Can we create awareness of personalized cancer therapy among oral healthcare professionals? And most important, can we not educate the young, aspiring dentists and guide them through the correct path to conglomerate oral cancer clinical research into clinical practice? I just pulled up all my thoughts in this one slide, and you are very much free to share your thoughts as well, because I want to learn from your sharings. Because these are certain things we really now need to think. We are not back anymore when it comes to science and technology. It's just that we need to explore it in a right way. So, thank you very much. And I just want to mention, though, with Dr. Dua's story, I started a bit in a low note. I just want to mention that this is not the end. It is just a new beginning, and we have a lot of work to do. Thank you so much. And well, I think I'm extremely honored today to have Sir with us, Dr. Kripa Johar. And now we are going to experience a fantastic session where Sir will take us through non invasive laser therapy technologies and how we can at least do something at our clinic level when lesions like precancerous lesions comes, or you are handling patients who have undergone some cancer therapy, because there is lot of pain out there we need to ease. Thank you, sir, for joining today, and
Thank you.
thank you for accepting our invitation. So I would just like to mention that Dr. Kripa Johar is a name, and as a person, I'm very blessed because he's my mentor. I have learned dental lasers from him, and he is a pioneer figure in India. Today, there is a lot about laser dentistry, but from the time people didn't know about lasers, Sir brought it into India, and that's why I feel very privileged whenever I interact with Sir. Sir, we are all waiting for your session very eagerly.
Yeah. Thank you, Dr. Gargi, for having me over here. It's my privilege and honor to be part of this program. And like I've told you, I always admire the work that you're doing in
Thank you, sir.
genetics and trying to improve the quality of life of patients who suffer from this deadly disease, and also through genetics where we can be more preventive in disease detection, early detection, and avoid the side effects of some disastrous diseases. So your contribution in this field is tremendous, and seeing your work in the last few years is truly amazing.
Thank you,
And
sir. Thank you so much.
seeing hearing your lecture and the unfortunate incident that affected this young doctor's life, and the way forward has to be a positive note. And we as doctors, general doctors, dentists, uh, oncologists, all need to come as a team and find solutions to help improve patient care. Dentists in their own clinics, if they can add early detection, because we are the ones who see the oral cavity first. So I think that is something which is lacking, unfortunately, also amongst the dental community, where concentration is more on the teeth and oral mucosas are not always checked, which I think needs to be improved on, right? So, and even if in whatever way we can help our patients, early detection would definitely, if we can refer it to another specialist oncologist at an early stage, we will be doing a very big service to the patient.
Absolutely.
Yeah.
Absolutely, sir.
So that is one thing which all we need to do is just refer at the right stage, because we are the people who check first. So that before it's too late and they run to the rush to the oncologist, right? So today I'll be talking about laser therapy. So as a dentist, how we can help our patients. So laser therapy is something where we can, I would say, improve the quality of life for somebody who's undergoing chemotherapy or has undergone chemotherapy, and improve the quality of living, improve uh, uh, their eating abilities. A lot of times post chemotherapy, patients have difficulty in swallowing. There is a condition called as mucositis. Mucositis means reduced saliva. So when there's reduced saliva in the mouth, the patient feels dry, has a dry mouth, has difficulty chewing food, In fact, I have seen cases where the patient's own teeth start jaggering their tongue because the mouth is so dry, and that itself is so painful for the patient that they can't even swallow their own saliva. So that's where laser therapy comes as a useful tool, where applying light, just applying light on the area inside the oral cavity or even outside the buccal through the cheeks can help in giving improved salivation and increasing muscle tonicity and helping in the patient swallowing, helping the patient chew better, which is a tremendous help to the patient. I'm not saying that we can eliminate the deadly disease, that's beyond our control as dentists, but at least we can provide them better oral health and better general health because they can eat better post chemo. Also, once you have you have a detection of cancer, it's very important to keep the environment oral cavity free, clean of infection. Just applying light, laser beams on into flashing light into the oral cavity can help in achieving a completely aseptic environment in the oral cavity. That's another very advantageous use of laser therapy. Other than that, post chemo, mucositis, dry mouth, difficulty in chewing, in all these conditions, we can use laser therapy. So does this involve complex machines or anything? Not laser machines, nothing like that. All you need is a simple handheld laser device, which is not too expensive in today's times. You need the right wavelengths. They come in around 660 nanometers or 808 nanometers. A 660 nanometer device is all that you need to help your patient out. If you want, you can even, a patient who suffers from cancer can even keep this in their house and use it on their own. They can apply the light on the area that is in the oral cavity and around the buccal mucosa or wherever they feel some pain post chemo. It can help them in healing. It can help in chewing, and it can help them in improving the quality of their life. So we'll just demonstrate how a simple laser device looks. So this is a simple handheld laser. It's as small as this, and it has simple applications. It just has an on and off thing. It's a handheld machine, and we will show you how we can apply this in the oral cavity. We need to wear glasses. One second, Richard. Glasses, please. So we need to wear glasses when we're using this machine, and we can apply this in the oral cavity and help the patient get relief from these deleterious side effects of chemo. Other than that, even in early precancerous lesions, if a dentist, it's not only in proper cancer, even in a precancerous lesion like leukoplakia, lichen planus, OSMF, we can use the laser for improving the situation of even precancerous lesions and give the patient better elasticity in the oral cavity, reduce symptoms of itching, burning, faster healing, so that the patient can have a better quality of life even at a precancerous lesion of leukoplakia, lichen planus, OSMF. And this is something that dentists can do in their dental clinics. Any dentist can learn basics of laser therapy, and if they have the right machine, a small investment like this, any right way machine that they have, they can actually help so many people who suffer. Even a precancerous lesion like leukoplakia, lichen planus, OSMF, what are the common symptoms that our patient tells us? They have burning mouth, they have difficulty in chewing, they have limited mouth opening, they can't eat spicy food, they feel itchy in the buccal mucosa, they feel uncomfortable. So all these conditions you can improvise by just applying light. Even OSMF conditions, you can have improved mouth opening by just applying light on the bands, and it's completely non-invasive, it's completely painless compared to giving steroid injections at the bands, which are so painful. And also, this can be done repeatedly over a period of time. And if the patients want, they can even do it on their own in their house if they have a simple device, if they have some basic training. So there is so much we as dentists can do to improve the quality of life of our patients. And I think it's high time dentists, since we are talking about oral cancer, and when we talk about oral cancer, we can't eliminate dentists because they are the primary caregivers in this area. And it's really high time that dentists understand that they can do more to help their patients. I'm sure we dentists want to do more for our patients. It's just that there's lack of awareness. And once they know that they can in some simple way help their patients, most of the dentists will be more than happy to incorporate this in their practices. And for patients who unfortunately have severe symptoms or can't travel regularly to the clinics because the disease itself is so deadly, the and the treatment is as tiring as the treatment is as tiring as the disease. So all the more we, if they just want to do the laser on their own in their house, that itself they can use a laser device and do that. All right, so I'll just show you all how to apply the light in the oral cavity. So this is a simple laser device. There's a charging point here. You have to put it on charge. You'll just be bringing the charging point. So it has a time interval and it has a mode of on and off, and it has a mode of continuous of pulse, and it can start and stop. So very simple, nothing complicated, not too many applications, not too many buttons. If you keep a simple machine, if you have a simple machine with you, even a layman can use this. So it should not be something difficult for a dentist to incorporate, for sure. So this is how you start the button. And then very important is the patient or the dentist both wear glasses when they operate with the laser light. And this is how the laser light looks. Okay, so you can apply this. Am I visible?
Yes, sir, you are visible.
Yes, so this is how you can apply this light. The patient can apply it directly on themselves, or the dentist can do this under the tongue with the salivary glands open on the buccal mucosa. You can even apply it outside. It's not only laser light is not only for post chemo precancerous lesions, since that's our topic today. I'm telling that, but a simple laser therapy handheld unit can be used by dentists for so many cases in ulcers, traumatic ulcers, any kind of lesions in the mouth, post surgeries, post surgery healings. We can use it post wisdom tooth extraction, paresthesia cases after a wisdom tooth extraction, trigeminal neuralgias, Bell's palsy. All these conditions we can apply light for faster and better healing. So wonderful, wonderful tool, so easy to use, and such wide range of effects and such wonderful effects. It's a wide range of treatments and so simple to incorporate.
Yeah.
All that it requires is a simple training and a right device, and the dentist is good to go. Yes. So
It
you're
was
telling me
fantastic,
something?
sir. Yes,
Yes.
it's really amazing, and the way you demonstrated, I think everybody got a very very clear idea, and it seemed like it's just like a torchlight. I mean, you
Yes.
just press that
Yeah.
button and do. It is as
Yes.
simple as that. So, sir,
Exactly.
can you tell us that if somebody wants to procure, then where they can, find your Haridan
Yes.
laser
So,
therapy?
see, there are a lot of laser devices in the market. The laser manufacturers are there. You can reach out to the regular laser suppliers who deal with your dental machines. We have come out with a personalized handheld device other than a big laser machine so that the investment is lesser for the dentist, and it can also be used by general physicians, paramedical nurses, caretakers of the patient at home. So we have devised something keeping the general population in mind and also the dentists to use in their practice without feeling the pinch of investing something very thing. So we have used a simple machine basically. This is available. You can just reach out to me. It's available through my website. It is available through WhatsApp. You can send me a WhatsApp message, and the details are all there on website. Very soon we'll be launching it on Amazon and Flipkart also. And our aim is to reach out to dentists and to patients who need this, and all across India, and help, so for doctors to help their patients and for patients to help themselves, to empower themselves for better quality of life and a better post-operative healing. That is what we are trying to achieve. So these laser therapy devices come in different wavelengths. So you have normally 660 nanometers and 808 nanometers. 660 nanometers is red and 808 is infrared. We have used a 660 nanometer because it helps in faster healing and for superficial wounds and injuries. 660 is a good wavelength, and that is the reason I have gone with 660, keeping wider range of applications and simplicity of use for even patients to do on their own. So I'll demonstrate this just once again for convenience. So we incorporate this, and then we on the light. Okay, so now the next question will be, if you can see me applying the light, is how long do I apply the light? So the light can be applied for say 10 minutes per area, 10 minutes here and 10 minutes here. We can apply the light. And so basically we have inbuilt in the machine, we have a 10-minute switch off button. So after 10 minutes, it will switch off on its own. So you can keep it at one area and flash the light there for 10 minutes, another area again for another 10 minutes. So if you, supposing if the patient is coming to a dentist, they can do it 3 times a day. I mean, daily once. If it's a patient doing it on his own at home, he can do it 3 times a day also. But if we are going to a patient, how often should I be calling my patient? For this, supposing the patient can come, you can initially post chemo call them daily for a 10-15 minute session. If commuting is a problem or other logistics don't work, even one session once a day is good. Once a day, once a week is also good. I mean, so uh, there are no side effects, there is no contraindications. The more we apply, the better it is. So laser beams are nothing but just light, and like I always say, from olden days in our Indian history culture, we know light is good for healing. Sunlight, if you take example of sunlight, we know it has healing properties. So basically, laser light is nothing but the right wavelengths of light available in nature, which we have utilized for healing purposes. So this is about which wavelength and how it works, about the thing. So how does it work? Basically, laser therapy with the light which comes out of this, of any laser therapy device, right? So if you can see, this is continuous mode. If you do it in pulsing, you'll see the light flashing. All right, so both the modes can be used, continuous or pulsed mode. It doesn't really matter. For simplicity case, for a starter, continuous mode is more than enough. All right. So, how does laser light work? How is it able to provide relief to our patients? So, basically, laser light works at a cellular level. It's not just giving stimulatory effect, it's working at a cellular level, and that's a very big advantage that lasers provide compared to traditional treatment modalities. So, what happens is our cells have mitochondria in it. The mitochondria has photoreceptors inbuilt in them. So these photoreceptors which are there in our body absorb the laser light, and that helps in healing. It helps in increase free radical oxygen, and it improves the cell energy in the cell. So the cells which are sick get energy light, and they start to recover and gain more energy and more ATP production, and that causes faster healing. It also improves lymphatic drainage, so it reduces swelling. So there's so many kind of advantages which the laser provides. We have a question from Dr.
Yes,
Deepa
Dr.
Patil,
Deepa Patil.
which soft
Uh,
tissue laser should be used. Doctor, are you asking for surgery or are you asking for therapy? If you can clarify that, I will be able to guide you more precisely, because there are different devices for both. Uh, you
so we
can
have
get
another question. We have
devices.
another
Okay.
question. Maybe till Dr. Deepa writes, we can just take up this.
Yes.
Uh, this is from Dr. Padmavati S. She asks, what is the success rate of this method in patients?
See, you're asking for laser therapy for healing. We are not doing any surgery, right? We are trying to cause healing of the tissue. Laser light for therapy is a very long FDA approved procedure, long lasting, used from more than 10-15 years. Most of the times, in 95% of the cases, the patient gets his relief. So success rate in terms of, I can guide you in terms of surgical procedures better. This is a therapy like physiotherapy. So this is a therapeutic modality. Most of the times, the patient gets relief, and it's in more than 95% of the cases.
Sir, we have one
I
more question, and I think we will wind up with this question, because then
Okay.
we will move towards the activity that
All
the
right.
girls are waiting.
Yes.
So this is asked by Dr. Niraj Sharma. What is the energy density range of this laser machine?
Doctor, the energy range of this machine is now 15 minutes. That's also the joule calculation is inbuilt in this machine for convenience. Uh, so 15 minutes. 15 minutes gives you 135 joules. That is already inbuilt. 10 minutes gives you 90 joules. So that is inbuilt in the machine. So you don't have to, otherwise, most of the machines don't have inbuilt recording of the joule calculations. You'll have to calculate it through some formula. Here, it's already inbuilt. So that is the amount of energy. So the parameters that are there in the machine are the wavelength. The wavelength is fixed. It is 660 nanometer wavelength. It doesn't change. And the energy which comes out is based on a certain calculation of the wavelength and the time used, how many seconds used. So that gives you, for if you use it for 15 minutes, you get 135 joules. If you use it for 10 minutes, you get 90 joules. So that's how the calculation works. All right?
Thank you, sir. That was an amazing
Yes.
session from you, and I
Thank
think
you.
it was because it's not like it was very practical session, I must say, because theory we can just go and read, but this kind of practical
Yes.
insights we generally don't get very often. And thank you
Yes.
for your time. Thank you so much for
Thank you,
being here.
Dr. Gargi. Dr. Gargi, just one more minute. That one question which was unanswered by Dr. Deepa Patil, I think.
Sure, sure.
She was asking which is a good laser device, which soft tissue laser should be
Should
used.
be used. Yeah.
So, is she a dentist? Any idea? Or so I'll just
I
briefly
don't.
tell you. Okay, so Doctor, if you're a dentist, you have surgical lasers called diode lasers. Diode lasers would be the best for a clinician if you want to do general dentistry. If you're talking about laser therapy, this something compact and portable like this probably might be the only machine in the market. Was this something we have done with research over the last 1 or 2 years time from the lockdown actually. So in terms of therapy, this would be the only machine. Diodes, you have different companies for surgical dental machines. You have Indilays, you have Biolays, you have Pion. So you have different kind of devices which can be used. I hope that answers your question. Yeah,
Thank you so much, sir, for being with us. And
my pleasure. Yeah.
thank you so much. So now we move ahead to our next phase of this event, and let me bring the gang up here so that we all will be together in this, and let's see what they have to show us. So we are doing a small activity based on the basic concepts of the gold standard biopsy. Welcome, Dr. Mayuri, Gitika, and Shreya. So this is the troupe who is going to guide us through this particular activity. So just with the beginning, you can just introduce yourself, and you can just take this session, blow up this session. I can ask Dr. Mayuri to start. So Dr. Mayuri, can you introduce yourself?
Good evening, everyone. I'm Dr. Mayuri. I'm working as a senior assistant editor in Genome and Global magazine. And I'm very grateful to Dr. Gargi ma'am that she has given me the opportunity to be a part of this insightful program. So without much delay, we will just start our activity. We'll take a case scenario. Suppose a patient walks into a dental clinic with chief complaint of a red and whitey patchy lesion over the lateral border of the tongue, which gives him or her a burning sensation while having spicy food. So as a dentist, he or she will perform a clinical examination after taking proper history, but he suspects malignancy. There the dilemma comes that whether to perform a biopsy or not, or wait for a few more weeks or observe. The key to a good prognosis for malignancy is the early detection. So, today we will discussing the choice of biopsy procedure based on the appearance of the lesion and steps for performing the procedure. And at last, we will discuss something about the interpretation. As Gargi ma'am have told that it is an activity session, I want all of our viewers to be actively involved in this session. So we'll just start. I think the picture is visible to everyone. As all of you can see, the lesion over the posterior buccal mucosa. See, if you can see that it appears white in color. So maybe everyone could appreciate it. It is a case of thick homogeneous leukoplakia. It is full of keratin with hyperplasia of epithelium. It is epithelial in origin, as we can see. And so the biopsy, what is the main requirement of a biopsy procedure? The biopsy procedure always demands the tissue section in these cases with full epithelial thickness along with the supporting connective tissue. So what will be the benefits? That this will serve two purposes. First, give support to the specimen, and second, we will get to know the extent of the lesion, that is the invasive nature of the carcinoma. Now, I think the next picture below, you can see a dome-shaped swelling over the palatal area. Here the epithelium is intact, you can see, which indicates it is a mesenchymal swelling, that is connective tissue swelling. So always in these type of lesion, the color of this type of lesion represents the contents within it. So if the lesion appears red or purple, it is vascular. If it is blue, it is mucinous. If it is yellow, it is adipose or lymphoid. So how we will do the biopsy here? Here, we will need the specimen to have sufficient depth so that we can study the mesenchyme in detail. So, the essential requirement of a biopsy specimen is that the tissue represent the primary lesion as well as the surrounding normal area for better vision. We will need something to compare. We will need both normal as well as abnormal cells to compare. So, the selection is the most critical step in biopsy, site selection. So now we will discuss some of the particular type of biopsy procedure along with the case types, which every dental practitioner should be aware. See this lesion, you can see, look at this. This is a pink node over the buccal mucosa. You can see it is very visible and it is in an accessible site. It is adjacent to the occlusal plane. Most probably, you can see it is an irritational fibroma. What to do in this case? I think if dentists are also present in this session, they must be knowing. We will perform an excisional biopsy. What is excisional biopsy? It removes the lesion and the specimen itself can be sent to pathologist for a detailed study. What are the basic requirements of excision biopsy? That is a pedunculated axophytic lesion if it is less than 20 millimeter, and endophytic lesion if it is less than 15 millimeter size and 3 millimeter depth. So excisional biopsy procedure will be done followed with elliptical incision. So this simple procedure will remove lesion along with a few of normal tissue. See, I have put one animation. This is it looks like a JCB, where the JCB is seen eradicating the lesion. You can see it along with the abnormal lesion. It takes away some of the normal tissue also. So I think with this animation, everybody must be clear what is excision biopsy. We'll just move further. You can see this type of lesion. This is a very commonly encountered cancerous lesion. This is located at lateral tongue, right side. See the reddish patches. See, you can see the ulcerated areas can be observed. This is a case of erythroplakia. Lesion is, you can see lesion is diffused. So we can't do excision biopsy because excision biopsy will itself remove the lesion. But in this case, we can't do. So what we will perform? We will perform incision biopsy. Okay. So next. See this lesion. Let's see another case. It is a diffused homogeneous liquid lesion. In this picture itself, you can see a device. The biopsy procedure is also mentioned. You can see this yellow device. It is, I think most of you have guessed it. Yes, it is punch device. Punch biopsy method. It can be incisional or excisional. In case of excisional, it will remove the entire tissue. In incisional, it will take the tissue along with some of the normal tissue from the periphery of the lesion. Yes, why it is called as punch device? You can see this, the girl is punching the boy. Yes, exactly. The same procedure is followed, like punching action only. Similar, the punch device is used in downward, like punching the area with twisting motion. You can see this. This is a vesiculo-bullous lesion, most probably a case of pemphigus vulgaris. In this case, usually punch biopsy is preferred, but we will not take the sample directly from the ulcerated tissue. Why? Why we will not take? Because the reason being the twisting action, as I have mentioned, that punch device is used in a twisting action. The twisting action will detach the epithelium, and this vesiculobullous lesion requires both epithelium as well as the connective tissue to know the pathology between them. So what we will do, we will take the lesion from uninvolved area of 3 to 4 mm from the edge of the blister. You can see here, this is the blister. 3 to 4 mm we will take from the perilesional area. You can see this two type of media use. I'll just quickly go through it. Actually, in vesicular bullous lesion, we will have two types of comparison. First, direct immunofluorescent. In this, we need a special media called Michel's media. And for simple light microscopy, we will keep the sample in formaldehyde. So that's all. This is my session. Now I'll hand over the relay of this session to Shreya and Gitika. They will guide you how they will exactly give you the practical activity experience, how the biopsy procedure is done. So I think please enjoy everyone.
Thank you, Dr. Murray, for that fantastic, brief and a good beginning. Well, to all the viewers who are here watching with us live, if you want to put up your question, please put. We'll take it up at the end of the session. And as we were flashing, that we are glad to share that this event is accredited by American Council of Training and Development, ACTT, New Jersey, USA. So if you want to check your certificate, I have put up a link out there in the comment box. So you need to purchase the certificate with a very nominal price. Well then, so what do we have in bag now? Gitika and Shreya, who is going to enlighten us more now?
So I'll be taking up and continuing. Warm welcome to
Fantastic.
our audience. I'm Gitka Raj. I'm Genome Club member, and I'm thankful to Dr. Gargi for giving me this opportunity to present this here. I'm a second year BDS student at Bharati Vidyapeeth Dental College and Hospital, Pune. So let me just share my screen.
I think she is the youngest one in the lot. So I think, Gitika, you need to unmute yourself as well.
Yes.
Yeah.
I hope you can see my video.
Yes, we can see, and you need to put it in slideshow.
So, today I'll brief you about incisional biopsy as Dr. Mayuri had already briefed us about incisional biopsy. So, today I'll brief you about it. So, many of you would have heard this word but don't know the proper meaning and what happens in the specific type of biopsy. The term biopsy was introduced into the medical terminology in 1879 by Ernst Wissner. The first diagnostic biopsy in Russia was performed in 1875 by M. Rudnev. It is possible to make out three stages in more than 100-year history of the method development. An occasional use of histological procedure involving living organs and tissues accessible for observation and study, approximately until the 19th century. Restricted application of biopsy until the mid 20th century, and at present stage at which the method is widely adopted and is used in general and total with respect to human organism, not only in oncology but practically in all clinical specialties. So, if I want to explain the incisional biopsy in general terms, then it is a surgical procedure in which a cut is made through the skin to remove a sample of abnormal tissue or part of a lump of suspicious area. The tissue is then checked under a microscope for any signs of disease. It is performed by removing a wedge-shaped specimen of the pathological tissue along with the surrounding normal zone. As we can see in this slide, that is a pictological reflection. So now you all would be wondering when do we use this process and how it's done. So we have to carefully observe and palpate the lesion so that the decision can be made as to which can produce a more preparative specimen, and the tissue is then infiltrated with a 2% local anesthesia. The incisional lines must be deep enough to include underlying connective tissue to the level of muscle or bone. So now if we see, this is the armamentarium, this is the blade, and this is a blade holder. And these are used for taking the wedge-shaped incision, which we had seen in the previous slide, from mouth to skin or any damaged tissue of the body. And this we can see is a cheese cube, which has the consistency exactly like the tissue of our body. So if we take the incision, something like this, a wedge-shaped incision, we will be getting some incision like this. And this is a representation, this is just a simulation of the actual tissue specimen. So we get a wedge shaped incision, and if we place that, we have a slide here. On the slide, if we make a thin section and place the thin section on the slide, and on top of that we add the cover slip, something like this, and after staining this we send it to the laboratory. So now, as we had taken the incision, we had done the incisional biopsy. As we can see here, this was the armamentarium that we used, the blades, the blade holder, and the slide. As we can see here, the pictorial presentation. So now this was how the wedge shape incision was taken. Now we can see here in the second picture that we are taking the incision, and after taking the incision we obviously need to suture it. So now suture is inserted through the end, upward tension is applied while the tissue sample is dissected out. So now all of you must be in doubt as to when do we use this process. Dr. Marriott already briefed us about this. If it is a large lesion, or lesions in which the diagnosis decides whether the tissue is such that it needs to be conserved with the surrounding, or it has to be dissected by using radical therapy. These lesions are selected at a site away from an obvious ulceration or area of necrosis, as these are the areas of intense inflammation which make interpretation difficult. Now, what are the advantages of this biopsy? If the tissue mass is larger, this method is used. Or if it is useful when a punch or needle core biopsy methods prove non-diagnostic. So as we know, everything has the pros and cons. So the demerits of using this biopsy are: firstly, it is an invasive process and general anesthesia is mostly required. Secondly, it is an expensive procedure. And thirdly, biopsy tract may compromise future surgery. Hence, the solution to our demerits can be using cytology, as that is an inexpensive technique using minimal equipment, or we can use the needle biopsy, which is less invasive technique. So this was all about incisional biopsy. I hope you enjoyed and understood what I spoke today. Thank you.
Thank you, Gitika. That was nice, and you are getting good comments. I mean, people are liking it. They say this is very interesting and educational. Fantastic. So I think we have some more stuff left, and I think Shreya will do the justice. And today, I think we have tried to create a semi-virtual lab, however you name it. Well, Shreya, so what do you have in bag to present here?
Well, a very good evening to one and all present here. My name is Sreya Vedartham. I'm a member of the Genomeron Club and a final year BDS student at Bharati Vidyapeeth Dental College in Pune. So I shall just share my screen. Is the screen visible to everyone? I hope it is visible. So, as Geetika has just beautifully explained to us about what incisional biopsy is, let us move ahead to another aspect of this topic. Today, I shall be talking about, in brief, about another type of biopsy known as punch biopsy. So, as the name
Shreya,
suggests,
sorry, Shreya, just to interrupt
yes,
you, can you make it in slideshow?
uh,
Your
ma'am, I did just a second. Is it not on slideshow?
no,
Okay,
it's not covering the full thing. There'll be
just a second.
option to do so.
Yes, ma'am. I'll just reshare my screen.
Yeah.
Ma'am, is it
Yeah.
visible now?
Perfect. Yeah.
Okay. As the name suggests, sponge biopsy, it is basically that the tissue is punched out using a hollow and a cylindrical scalpel. And as you can see in this method, Uh, so the first and foremost step to performing this type of biopsy is that the the tissue surrounding the lesions is anesthetized, and then according to the size of the lesion, an appropriate biopsy punch is selected. So they are available in various diameters ranging from 2 to 10 in size. So here I have two. As you can see from the tip diameter, they are either 2 or 4 in size. And the other armamentarium that you require are tissue forceps and something to incise the tissue. So let us now see how this is performed. So here I have a sponge that will be acting as my mucosa for the day. And here I have a 4 mm biopsy punch. So the punch is inserted into the tissue and it is rotated in a back and forth motion till it completely penetrates the mucosa. Then using the tissue, the section tissue is grasped using a tissue forceps and incised at the base to release a cylindrical or a circular type of tissue. So, like it will appear something similar to this, like a cylindrical or a circular shaped specimen. You will obtain it. So now that we know that this, it's a very basic procedure, as you can see, you just punch and you remove the tissue. So what advantages or disadvantages do you see here? So if you use a small diameter punch, it allows you to it has the benefit that you don't require suturing after the biopsy is done, and the site of the biopsy heals with secondary intention and it leaves only a minimal scar. But however, the problem with this is that if you use a smaller diameter biopsy punch, the tissue may be over manipulated and it may cause curling or crushing of the tissues. So generally, to overcome this, a 4 mm diameter punch is preferred, and this minimizes the curling of the tissues. Punch biopsy is a very easy procedure, and it is more advantageous in cases where the tissue is bound or it is attached to the underlying surface. For example, the tissues of a palate. But at the same time, it is problematic as the deeper lesions, like the deeper tissues, cannot be obtained adequately, and it cannot be easily used, and it is particularly difficult when the tissues are movable. So now this arises the question, like, where do you use this type of biopsy then? This type of biopsy is most preferred in cases of superficial small lesions, which involve some part of the epithelium, as in the whole of the epithelium, and some part of the connective tissue. So to summarize, I have a small video for you all. So punch biopsy is an easy, and it is performed easily by all of us. Like, it can be performed easily, and it requires disposable, simply available uh, armamentarium. So now that we have obtained the tissue specimen, as you can see, you incise the tissue and you obtain a specimen. This will arise the question, what next? So let us see what you do further. The next step to after obtaining the tissue is to process this tissue in the lab to determine the pathology. So this is done as soon as the tissue specimen is removed from the mucosa. It is fixed using a fixative like formalin. Then it is dehydrated in order to prevent decomposition, and this is done using a type of alcohol. And then subsequently, this is cleared using a clearing agent so that the alcohol does not retain in the cells. Next, the step is to embed this specimen in a wax block, and then finally it is sectioned into thin sections that can be placed on a microscopic slide. The next step is tissue staining. This is one of the most important steps, and this is done using a Copland jar. As you can see here, I have a Copland jar. The staining solution is present inside, and the slides are placed in sections. There are certain sections I can see in the diagram. There are sections in which the slides can be placed. So if you place the slide and allow the staining process to occur, and you remove it, it will appear something like this, like a stain slide. So after this, finally, you come to the tissue viewing and the interpretation part. You place the slide on a microscope and you interpret to arrive at a diagnosis. Now, Dr. Mayuri will tell us a bit about the interpretation. Thank you.
Thank you, Shreya. That was awesome. And the way you made it simple for everybody, I think it's very valuable knowledge, not only for the fraternity, for the students who are watching, and it's just a brush up of the basics for me as well. And also, we have our common people who are watching. It gives them also a good idea, because I think when it comes to biopsy and stuff, as clinicians, it is very difficult to sometimes to convince the patient. So I think with your presentation, it's very simple and it appears very simple to to our common people as well, and they know now that biopsy is not really a kind of surgery that we are going to do on them, but it is for their good when it is needed. Okay, so I think we are coming to the concluding part of the session, and we have now just to wind up and make the circle round. Dr. Murray will tell us about the interpretation of a biopsy report, right, Dr. Murray? So
Yes,
here we go. Thank you for this
please share.
amazing energy, audience, because I think without this, no session would be good, and we really feel more, more enthusiastic to bring up something like this. Thank you so much for your active participation. Yes. So we are good to go, Dr. Mary?
Yes, ma'am.
Great.
As Geetika and Shreya has very well explained, I think by now everybody must have well versed with the term incisional biopsy, excisional biopsy, punch biopsy. So by now we got some idea about the biopsy procedure, but what after that? We'll get a report. For a normal person, when they will see the report, they will be very confused because it is just a haphazard picture. So here we will take a case report and we'll try to make it more simpler and more comprehensive. So actually what does the report tell? Report tells that whether the lesion was malignant or not, and based on that only line of treatment will be decided. So let's take a case report. Uh, as you can see, a 59 years old lady with a chief complaint of severe periodontal disease. Mind, just listen carefully. She has not gone for a cancer. She has not gone for a complaint regarding cancer. She has other complaint like with a severe periodontal disease. She also gives a medical history of surgery 10 years back due to fusion of cervical vertebra. She is a patient of mild anxiety also. But the most important point is she was a chronic smoker since 40 years. Yes, it is in India. I think now the incidence of smoking among males and females are getting more equal, but in abroad it is very much common. Like the females also have the habit of smoking. So, after clinical examination, she was found to have stage 4 grade C chronic periodontitis. But an unusual finding was also present at the time. The dentist noted that it was 1 centimeter into 1 centimeter non-scrapable white lesion with red indurated border at lateral and ventral surface of the tongue, as you can see. On asking, she gave a history of intermittent burning sensation in that area. So, what will be the next step? Because now you have watched the complete session, what will be the next step the dentist will perform? Yes, I think most of you have guessed it right. Due to history of smoking, lesion seems to be suspicious. So the dentist decided to perform elliptical incision biopsy. I'll not go in detail about biopsy procedure now because I think this has been well explained in previous slides. So after biopsy, a suture is placed. You can see. Okay. Now we will directly jump to the histological report. See, the histological, look at this photomicrograph. For oral pathologist, for dentist, it is a very common picture. But for a common man, this looks like something like jigsaw puzzle. So actually, this report only gives that the whether the lesion is benign or malignant and what will be the line of treatment. So if we will magnify it, this photomicrograph, we can see that the lesion is well differentiated stratified squamous epithelium. You can see this keratin pearls are also there. We will see more. You can see the cancer cells has infiltrated into muscular like stratified muscles also it has invaded. So And you can see, I think you can appreciate or not, you can see this yellow arrow. This is atypical mitotic figure. I think you can appreciate it, not very clear, but still. So the final report was it is oral squamous cell carcinoma, which has invaded the musculature of the tongue. Look at the thing that the patient has come for periodontitis complaint, and she was diagnosed with oral squamous cell carcinoma. This is the power of biopsy. So, based on this, line of treatment is decided. I hope now that it is very clear that biopsy can help in diagnosis and prognosis of any type of cancer and thus increases the chances of survival. And that's what is our motto, that we want a happy patient. Thank you, everyone.
Thank you, Dr. Mary, for that comprehensive explanation. And thank you, Shreya Gitika, for the wonderful presentation. So, yeah, I have one issue here with the payment for the certificate. So, Dr. Pradeep Bhandari, you can just get back to eventsicdg@gmail.com in this email address. So you can just put up your issue. So we can help you with a link for international payment for the certificate. So I guess this was a wonderful session, and thank you everybody for being such a energetic, enthusiastic audience. It gave us a lot of energy, and I hope that um, in future we will come up with more such events. So if you are visiting my channel for the first time, don't forget to subscribe it, because we come up with events like this, and almost every some every week we come up on Wednesdays and Fridays, and some things some sort we keep doing here, very very interesting. And well then, so we will take a leave from you, because you have been stayed with us for, I think now it's almost 1 hour 17 minutes and 10 seconds. That's what my clock shows. Okay, and thank you for the fantastic energy. Thank you so much. Thank you so much.